Good morning, everyone. I'm Daniela Murgia, and I'm from Vets4Ukraine 2022. Together with other specialists, we decided to put together a list of free webinars for you in order to raise funds to help Ukrainian people. We have here a slide of all the specialists that for the moment have joined us in the initiative, and you see here we have already some dates which we will show you also at the end of this live. There are some other specialists join us, so I think right now we are reaching like 24 European specialists offering their help, their webinars for you, webinars that you can access for free, and you can follow live, or if you cannot follow these webinars live, they will be recorded and you can access them in our library on Vetonia, the Facebook group. So we have, as usual, we have our slide about the message in the bottle. This time, the message in the bottles reports the initiative of, I think it's an initiative in the United States called the Street Dog Coalition, and basically some veterinarians are heading to Romania and Ukraine border to help the local vets with like street treatment, street medicine, and helping to set up a temporary shelter for abandoned pets, and they have published on LinkedIn this appeal. If anyone wants to join them, just please feel free to contact them. As all the previous times, I like to report again the page on Facebook of the Ukrainian Small Animal Veterinary Association, the USAVA. Please, if you are interested in understanding which are the all possible ways to help Ukrainian people, Ukrainian vets, please join their page on Facebook, because they really have many links to join if you want to help in any way, if you don't want to donate for the British Red Cross with us, with Vets4Ukraine 2022. Last time we had a webinar with Jackie Demetriou, and we like to organize for her a surprise. So we had as our guest the president of the Hellenic Companion Animal Veterinary Society, Stefanos Gladakis. And this was, I must say, a very successful event, because Stefanos has shared on his Facebook page the link, and therefore we have had loads of requests to join our group on Facebook by the colleagues in Greece. So if you out there know any other small animal veterinary association presidents that you think they might be happy to join us, or to visit us or be our guests, feel free to let them know, and we would be happy to host them here in one of our live episodes. So now, before going to the meaningful part of this event, I would like to remind you to share the link, to share this live, to share the Vet on Air Facebook page to your friends, colleagues, and families, because we we would love to reach as many people as possible, and we really would like to raise as much money as possible to help the British Red Cross and helping the Ukrainian people in difficulty. So, Paolo, if you don't mind to launch the share countdown for me, I would be very grateful. So therefore, please share, don't be shy, share. And also, if you feel that you can donate a little money or some money to our initiatives, we would be very grateful. And also, thank you very much for joining us this morning. We know it's Sunday morning, and very likely there are other things that you might want to do on a Sunday morning. But today we have a really exceptional webinar presented by Professor Rob.White. Professor Rob.White is professor at the University of Nottingham and is very estimated soft tissue surgeon. He's a specialist in small animal soft tissue surgery. I don't want to present him too much because he has done an excellent video message and appeal explaining also what his webinar will be about. So I would like to ask Paolo to share the appeal that Professor Rob.White sent us, which we have already seen, but I would like to show you it again so that we can give Professor White the opportunity to present himself and present his webinar. So Paolo, please, if you can share.
Hello, my name is Rob White and I'm Professor of Small Animal Surgery at the University of Nottingham. I'm very grateful to be part of Vets4Ukraine 2022 and I'm delighted to have been given this opportunity to raise funds for the Ukrainian humanitarian appeal run by the British Red Cross Society. My talk will be around basic surgical skills and hopefully it will be very practical in nature. The plan is to live stream a number of useful basic surgical skills, so please feel free to have some surgical instruments available on the session. Ideally maybe some cord or string so we can tie some knots, and ideally, if you can get hold of it, some suture material with a swaged on needle on it. And then in addition, maybe something that we can actually suture. So an orange or a lemon, that would also be handy. If you can have those things available at the time of the talk, you'll be able to follow me live. I really hope you'll enjoy the skills and find them helpful in your daily surgical practice. The talk's scheduled for 10:30 Greenwich Mean Time on Sunday the 27th of March, but please don't worry if you can't attend live. We'll make sure it's recorded and we'll make sure it's available to you after the event. Most importantly, if you're enjoying our talks, please visit our Just Giving site and donate as much or as little as you can to help with this most vital and pressing of causes. Thank you, and I really look forward to seeing you on Sunday.
Thank you, Professor. We are very grateful and delighted to have you with us, and I'm very excited to follow your webinar, which, by the way, might be very useful to junior vets, students, and interns, and all those people that have not much much possibility to do surgery and to use these technical skills. So I'm very happy that we have Professor Rob.White here today with us. And without any further delay, I would like to give the words to Professor Rob.White. But before doing that, I would like to remember that you could interrupt Professor Rob.White with your questions. Just feel free to ask questions along during the webinar. And also we have the final Q&A session where we will try to answer your questions as much as we can. So I think for the moment, I would like to give the word to Professor Rob.White. Thank you very much, and I'll see you later.
Thanks, Daniela. That's a very kind introduction. And thank you so much, Paolo and Daniela, for putting all this together. Paolo's had to deal with my non-technical skills, and he's dealt with them very patiently. Hopefully, everything will work out okay today. So basically, what I'm going to do for the next probably hour or so, maybe a bit longer than that, depending on how much you want me to show you, is I'm going to go through some basic surgical skills and some instrumentation, some knot tying, and I'm going to hopefully add in some tips and tricks that will be helpful to you, both as students and nurses, and also newly qualified vets, etc. Possibly even if you've been qualified for a number of years. Hopefully there'll be some bits in here that you may not have been aware of. So I'm just going to try and change the camera to put it onto the overhead camera, which should be there now. And so you should now just see a suture board and my hand, if that's okay. So I talked a little bit about what things you might want to bring to this, and I talked about a couple of textbooks. So let me just show you what I meant by what you might be able to do with the textbooks. So let me just make the screen go a little bit wider. So with two textbooks, if you had those and you had some fruit, for example, here's an orange, you might be able to wedge that between the textbook covers, and in doing that, you can use that as a surface that you might then be able to stitch pretend skin, for example. And also when we're doing some knot tying, you might want to use something like a pencil or a pen, and you can put that through the pages of a heavy textbook, and you can use that as the structure that you're going to tie the knots against. And then realistically after that, you probably just need some cord, and then hopefully some surgical instruments that you might have handy. But as I said in the original clip, don't worry if not, because we're going to record the session, and therefore you should have it available to you in the longer term, so you can come back and review anything that I'm going to show you and practice it in your own time. So let me just move those things out of the way, and I'll put my board back, and then we can start. Okay, so we're going to start with just a two-handed hand tie. So I'm going to just do some hand tie knots, and we'll just go through knotting. And then in amongst this, I'm also going to show you how to tie a tension knot, which is one of the most useful knots that I've, I suppose, been taught over the years. So if this is our imaginary wound running from left to right, most of us, regardless of whether we're left or right-handed, probably with a preference, if we had a suture material with a needle on it, would take the needle from the far side to the near side. And that's just to do with how comfortable our hand is when we turn the needle through. We tend to feel more comfortable with in the hand in this position, which is in the prone position, and we turn it through and end up in the supinated position. And it's more uncomfortable to start in this position, this side, and turn it the other way to come out this side. So most of us will go from the far side to near side. So most of the knotting I'm going to do, that's exactly what we'll do. We'll start with the suture coming through the wound from the far side to the near side. My cord is coloured, so it might just show up slightly easier for you to see. And so if this had a needle on it, this will have the needle. It's coming through the wound and through to the opposite side. Now, I'm a right-handed surgeon, so I might have my needle holders in my right hand, and therefore I might prefer to tie knots with my left hand, because I might have the needle holders palmed off in this hand, and we'll talk about that palming off a bit later on. So I'll show you it off both hands, and actually for the knot tying with hands, ideally it's best if you can do it off both hands. So the sutures come through. So this would be the short end, and this would be the long end with a needle on it. And I'm going to tie the knot with this left hand. So there's sort of two bits to knot tying. There's the formation of the throw. So that's the throw. And then there's the lay of the throw. And the lay of the throw can go one of two ways. It can either go the correct way, or it could go the incorrect way. And practicing with cord is really helpful, because you can see the knot that you're creating. And what we're trying to create is a square knot, or a reef knot. It's the same thing realistically. So here's the suture gone through, and I'm going to put the long end into my palm of my left hand, and it's coming in between the V of my thumb and my index finger, and I'm just clamping it off with my middle finger, ring finger, in this case, little finger. And the basic action between each throw for a two-handed throw is either the suture is going to be on the forefinger like that, the index finger, or it's going to be on the thumb like that. So between each throw, that's what you're going to be doing. You're going to alternate. One throw is going to come off the thumb, and one throw, the next throw is going to come off the index finger, next throw off the thumb, and vice versa. So that's the basic action that you're going to be doing. Now we've just got to decide, therefore, which one we're going to start with. And there's no real magic to that. It all depends on how the suture went through the wound. And in this instance, it went from the far side to the near side. So you just have to take my word for it that you need to start on the thumb. We can have a go off the index finger in a second, and you'll see that it puts a twist in the suture. So I'm starting on the thumb. I'm then going to take the short end and make a cross on my thumb. And I'm going to then bring the tip of my index finger to the tip of my thumb. And then I can take them as a unit through the loop that I made. And then I can take the adjacent short end between the tip of my thumb and my index finger and hold it. And at that point, I can let go with my right hand. I can then take the whole lot back through the loop, re-grasp the short end with my right hand. There's the throw. And the lay, in this instance, to make it go down squarely, means my left hand needs to go away from me and my right hand comes towards me. So let me just quickly show you what happens if you did it the wrong way round. So if we started this off the index finger rather than the thumb, there's a cross, tip comes together, goes through the loop, takes the short end, let go with the right hand, go back through the loop, re-grasp it. There's a twist now in the suture. So the only way I could get that to lie straight is to do some sort of contortionist act to try and get it to go straight. So knowing which to start it on is something you'll just have to practice, because when you're using suture material, not cord, it's much more difficult for you to see exactly what you're doing. Anyway, let's go back to where we were. Here's the suture that's gone through the wound. I've got it now in my left hand, in the palm. It's grasped with my middle finger, ring finger, and little finger. And this is the basic action. I'm going to start on the thumb, make a cross on the thumb, tip of thumb and tip of index finger come together, go through the loop, take the adjacent suture, let go with my right hand, goes back through, re-grasp it. There's the throw, and there's the lay. As I come up, I go on to the index finger. And then I put the cross on the index finger, tip of the thumb and the index finger come together. They go through the loop, take the short end, let go with my right hand, goes back through the loop, re-grasp it. There's the throw. And this time, the lay to go squarely, my left hand comes towards me and my right hand goes away. And then I'm going to repeat the process. I'm going to go back onto the thumb, cross, together, through, grasp, let go, back through, grasp, down. And so if I come in and just show you what we've done, you can see that I've put a reef knot after a reef knot, or a square knot after a square knot. You can see that they're correctly tied, and we've not produced the granny knot, which is asymmetrical and wouldn't have the knot security that we're looking for. So what happens if we do it off the other hand? So just show you how to do it on the opposite hand, which I guess if you're left-handed, you might choose to do maybe more frequently. So here's the suture material. It's coming through the wound. And this time I've got the long end in my right hand and the short end in my left hand. The basic grip's the same, it's just in reverse. So I've got it grasped with my right hand, and it's either going to be off my thumb or my index finger. Put it onto the thumb, cross on the thumb, tip comes together, goes through the loop, grasp the suture, let go with my left hand, takes it back through the loop, re-grasp it with my left hand. There's the throw. Right hand now goes away, left hand comes towards. Come back up and go onto the index finger. cross goes on the index finger, the tips come together, go through the loop, takes the short end, let go with my left hand, back through the loop, re-grasp it, there's the throw, and this time my right hand's going to come towards and my left hand's going to go away. And there's the square knot. So that's the sort of basic two-handed knot tie that we tie and we use. And obviously once you get used to it, you generally make it into a sort of single process. So it's not becomes this laborious thing where you're splitting it into stages. But when you're trying to learn it, it's quite a good idea if you break it down into its component parts. We can also tie a surgeon's knot. So a surgeon's knot will have 2 throws on the first throw. So currently this has got 1 throw on the first throw, but a surgeon's knot would have 2 throws on that first throw. So it's going to look something like that. So there's more friction between the 2 threads, and therefore it's less likely to loosen between the first and the second throws that you're trying to develop. So how do we do that with the two-handed tie? Well, if I just undo it, we'll go back to where we were. So I've now gone back onto my left hand. So this is the long end, and this is the short end. I'm going to put it back into the palm of my left hand. Here's the basic position. So they're going to come off the thumb or the index finger. So let's go on to the thumb to start with. There's the cross on the thumb. Tip of the index finger and the thumb come together. They go through the loop. They take the adjacent suture. I'm not bringing this loose end up. I'm taking the adjacent suture that's just there. Then I let go with my right hand. I pass it back through, re-grasp it. But to do the surgeons, I don't pull this down. I put the tip of my finger back to the thumb, take it back through the loop for a second time, re-grasp the suture for a second time, let go with my right hand, go back through the loop. There's the 2 twists, the 2 throws for the surgeons, and then I take it down. Next throw is going to be a square throw, so I come back up onto the index finger, cross over, tip of index finger and thumb come together, through the loop, take the adjacent suture, let go, back through and down. Obviously then repeat it however many times you need to for the suture material that you've got in front of you. So that's the surgeon's throw or knot that we can tie with a two-handed throw. Now, lots of people would sort of ask, why do we need to do a hand tie? Well, one of the reasons why this particular hand tie is quite useful is that you can use it to tie a tension knot, which I'm going to do across this wider elasticated suture board. So if I just take this in slightly so you can see it a bit better and get a better picture of it. I mean, I guess there are lots of times some people will preferentially use hand ties when they're trying to ligate vascular pedicles. They'll just feel more confident that with a hand tie rather than using an instrument. But for some, it may well be that you don't use them very frequently. And I guess the problem when you don't use those things very frequently is you forget how to tie them. But there'll be occasions where you lose a surgical instrument or you haven't got a sterile surgical instrument available, and it's useful to be able to do a hand tie. This is the tension knot. So what I'm going to do now is try and close these 2 structures together. And they're obviously under some lateral tension. So if I take a suture, so I've just converted this now to a proper suture material and take it through. If I just put a single throw on this, so here's a single throw on it, I obviously can bring these edges together. But when I let go with the needle holder to put the second throw on, it's going to come undone, isn't it? Because of the lateral tension. So we may be able to sort that out by putting a surgeon's throw on it. So let's just try that. So let's put 2 throws on. So there's 1. Let me just get this to stay through. It's got some memory on it, this suture material, so it doesn't want to stay. So let's put 2 throws on it. 1, 2, and take it. And let's just see if this is going to have enough friction now to stay together. I suspect it probably hasn't. No. Okay, so it's still coming apart. So what we can do is we can combine a two-handed hand tie with an instrument. And so the instrument in this instance is going to be in my right hand as a right-handed surgeon. So it's going to basically be acting as my right hand. So here's the suture again through the wound. I'm going to put a single throw on it this time, which will just make it slightly more difficult, I guess, won't it? Here's the wide part of the elastic. And we've decided that if I don't keep equal tension on this suture on both sides, it will come undone. If I release with the needle holder, it comes undone. If I release with my hand, it comes undone. But if I keep equal tension on both threads, it doesn't come undone. It stays together. So what I'm now going to do is go on to the forefinger. So this is the second throw of the two-handed hand tie, and it's around my index finger. And you can see it's blanching the finger slightly because I'm pulling on it. So I'm keeping tension on both sides. I now take the short end and make a cross on the index finger, and I'm still pulling on it to the degree I've just lifted the board off the table slightly. But this time, the tip of the thumb doesn't come to the tip of the index finger. The thumb goes onto the cross that I've made. And that means that the tension is still being maintained, and so I can let go with the needle holder. The needle holder goes through the loop, takes the short end, pulls it back through. There's the tension still being kept. And I take it down, and there's the square throw tied. Now, it's likely that that will be sufficiently secure that I can then let go and put a third throw on it. There's the lock stitch, and any more I need to put on it to finish off the knot, depending on the material I've got. So that skill, I think, is a really useful skill to try and master, because it will allow you, under any circumstances, realistically, when you're confronted with a wound that's under some tension, to make sure that you can bring the wound together. So for me personally, I have to say, I relatively rarely use a surgeon's throw. I'll mostly use a square throw because I can tie the structures that I'm trying to ligate under tension, depending on the tension that's there. So I'll often, when I'm just routinely ligating a wound, tie it as a two-handed hand tie in my left hand, but I'm using the needle holder in my right hand rather than my right hand fingers to control the suture. So that's often one of the ways I'll standardly use to stitch a wound up, because it just gives me that ability, depending on what the wound is doing and how much tension it might be under, or if I need to put it, close any tension, to be able to achieve it. I mean, obviously, if this is the skin, we don't want that degree of tension on it, but there will be occasions where the wound that you're confronted with is under some tension, and I think sometimes people really struggle to know how to get that wound to close. So that's a two-handed hand tie, and that's the one of the derivatives of that we can use, which is a tension knot. Okay, so let's just move on, and we can talk about a one-hand surgical tie. There are lots of different types of one-handed hand ties, and lots of people will do a one-handed hand tie in different ways. The way I'm going to show you is a way that will allow you, if you needed to tie a surgeon's throw. But as I say, there are plenty of different ways of doing a one-handed tie, and you probably will have seen people doing it in different ways. So here's the suture coming through. This is going to have the needle on it. We said you prefer to go from the far side to the near side. So there's the needle coming through. And this time round, we tie the one-handed hand tie with the short end. We make the throws with the hand that's holding the short end, not the hand that's holding the long end. And just for consistency, because I'm going to tie this off my left hand, it means that the long end now has gone into my right hand, as opposed to my left hand that it was in before when I did the two-handed tie. And I'm going to leave the short end in my left hand because that's the one I'm going to use to produce the throws. So it's the opposite in terms of which thread you're holding. So the first throw with this, because the suture's gone through from the far side to the near side, is we're going to hold the suture like this. So I'm going to hold the tip of the short end between my thumb and my ring finger. My index finger and my middle finger are extended, and there's a gap of air. There's a space between those two. It's not closed up like that. There's a gap there. Because what I'm going to do in a minute is I'm going to bring my my middle finger down towards my palm, and then it's going to come around that short end, and it's going to clamp it between my index finger and my middle finger. So it's like that. And what I'm going to do is bring it down towards the palm, go around the short end, and clamp it. Show it from that angle. Down towards the palm and clamp it. Okay, so that's what we're going to do. And you can practice that as many times as you like before you actually produce the throw. Okay, so to produce the throw, what we're going to do is we're going to take the long end away from myself, but it's gone around my middle finger and my index finger. And now, when I bring my middle finger down towards the palm and do exactly what I've just shown you, and then clamp that suture, which is the blue end in this case, between my index finger and my middle finger, at that point I've got control of it. So I can let go with my thumb, and then if I pull that through, there's the throw, and my left hand is going to come towards me, my right hand's going to go away, and there's the lay. So let me just show you that again. So here's the suture. It's gone through the wound. Long end in my right hand, short end in my left hand. Grasp the tip of the short end between my thumb and my ring finger. Extend my index finger and my middle finger. And that's what I'm going to do in a minute. I'm going to take the long end and I'm going to go away. I'm then going to bring the middle finger down towards the palm, go around the short end, clamp it between my index finger and my middle finger. Then I can let go with my thumb, bring it through. There's the lay, the lay from the throw. And this would be the same on the opposite side. So let's just show you. So if I swap hands, it's exactly the same. It's just a mirror version of it. Okay, so I've got it held, ring finger, thumb, over the top. And down. Okay, so how are we going to do the second throw? So let's just put it back where it was. So here's the suture gone through the wound. I'm going to go back onto my left hand. Let me just come out slightly so you can see what's happening with the left hand. So let's put the first throw on. As I pull this down, I'm pulling it down and I'm holding it between the index finger and my thumb. So that's allowing me to tighten the thing up. As I come back up with my hand, I'm going to extend my middle finger, ring finger, and little finger. So this get extended, and then I'm going to exaggerate this. They're going to come out towards the left, and then they're going to come up towards me. I'm going to roll it into it like that. So basically, it's out there like that. So the suture's coming down and around and away. And again, I need to have a gap in here, because what I'm going to do once I've got it into that position is bring my middle finger down to the palm again. But this time, I'm going to catch the suture between my middle finger and my ring finger. So that's what I'm going to do in a minute. So I pulled it down, and as I've come back up, I've extended those fingers, and I've rolled the suture into my hand like that. Okay, so to produce the throw, I'm going to bring the long end down. Then I'm going to do exactly what I've just showed you with the middle finger, down towards the palm, around the short end, clamp it between the index finger and my middle finger, my ring finger and my middle finger. At that point, I can let go with my thumb, take it through. There's the throw, and there's the lay. Show you that one more time. I've pulled it down. As I come up, I've extended middle finger, ring finger, little finger. Take the long end over the top. middle finger comes in, round the short end, grasp it between my middle finger and my ring finger, then I can let go with my thumb, take it through the loop, and this time my left hand goes away and my right hand comes towards. And you're going to repeat the process, aren't you? So back to the first one we did, and down. And again, as you get more confident with it, you'll be able to speed the process up and turn it into something that's slightly smoother than the jerky action it might be when you're breaking it into steps. So let's just show you on the opposite hand. So the first throw that we did was like this. As we bring it out, we're going to extend those. I'm going to turn it into there. It's the long end over the top. Middle finger down towards the palm. Round the short end, clamp it between the middle finger and the ring finger. Well, it's not the ring finger this time, is it? It's the ring finger on my opposite hand as such. Let go with my thumb, pull it through, and there's the knot. So I said that you can tie a surgeon's knot with this, and that's exactly the case. So if we go back to the original hand, here's the suture coming through the wound. We're going to swap hands because we want the short end, so I'm going to do it with my left hand again. To do a surgeon's throw, rather than just going round once like that, if we go round again, this is slightly difficult to do with cord because it's quite thick, but basically that's what we've done before. But this time I'm going to go round it again. If I then do that, catch it and pull it through, that's put 2 throws on the first throw. So we can tie a surgeon's with that hand tie. So as I say, there are lots of different ways that you can do single hand ties. And the bizarre thing is you need 2 hands to tie them. So they're called one-handed hand ties, but you still need 2 hands to be able to do it. But this one will allow you, should you wish, to be able to put a surgeon's throw on it. Okay, so that's 2 ways of doing hand ties. And then I think the most useful thing to get out of that is that tension knot technique that we can do when we use a combination of a 2-handed hand tie with an instrument. Okay, I'm just going to talk a little bit about instrumentation now and just introduce some other maybe quite useful tips and tricks for you. So let's just get some instruments out and we can have a look at them. So I think most of you will be aware of some of the basic hand or holding procedures for instruments. One thing you may or may not be aware of is that you can buy left-handed instruments. So here's a left-handed pair of needle holders. Let me just move those ones out of the way. And you may have not really thought this through or believed that this was the case, but the ratchet on a left-handed pair of instruments is the opposite way round. So this is the left-handed pair, this is the right-handed pair. And there's a purpose for that. So if I put a right-handed pair into my right hand, it means that to knock the ratchet off, basically I just need to push with my thumb and the ratchet comes away. It's the natural way that your thumb's going to want to go. I'm going to pull it towards you to get the ratchet off. But if you put some right-handed instruments into your left hand for a left-handed surgeon, to get the ratchet off, you can't push with your thumb because that's going to push the thing together. So you actually have to pull with your thumb, pull it slightly towards you, which just makes life more difficult, especially when you're using scissors as well. So it's the same principle with scissors, because what we're trying to often do with scissors to get the blades to come into contact and cut efficiently is to slightly push with the thumb. I just over-exaggerate it, and that pushes the blades together. If I put right-handed scissors into my left hand and I push with my thumb, that's going to push the blades apart, so it's going to make them work less efficiently. So if you are a left-handed individual and you've not tried left-handed instruments, I can thoroughly recommend them to you. And there are various sources where you can buy them from. And it may be something that really makes a big difference to your surgical enjoyment and your surgical skills. So let's go back to the standard grip. So most of you, I'm sure, will be aware of the grip called a tripod grip. So the tripod grip, your ring finger goes through the ring hole, or the ring finger ring, and your thumb goes through the opposite one. And then what you do is you'll bring your middle finger down, and that stops the instrument moving in that plane. And then your index finger goes down the shaft of the instrument, which stops the instrument moving in the opposite plane. So this is a very firm grip to use. What we find with lots of our students is they have a tendency to put the fingers too far through the rings, and that makes it more difficult for them to use the instrument. And also the ring ends up quite a long way down, especially on the thumb, in terms of the phalanx. And so after a long operation, with the ring in this position, it starts to damage the digital nerve that runs down this aspect and this aspect of the thumb. So you start to get a painful thumb because of that. And also remember that the most sensitive part of your fingers is the tips. So the portion of the fingertip, which is in this third phalanx and on the thumb, is the most sensitive bit. So if you want to pick something up and get really good feedback from what you're doing, that's where you want to try and hold it. So we're trying to get into the habit of just putting the tips of your thumb and ring finger through, and that will give you better feedback. So that's your standard grip. And that's going to be a sort of standard grip for any ringed instrument. So here's some scissors, standard tripod grip. Okay. With needle holders though, once people start to come on postgraduate surgical courses, we start to talk about palming off instruments. So let's just explain why. So if I put my needle holder into a comfortable standard tripod grip, I just need to come out as far as I can so I can show you this, and put my arm flat on the table, that's a comfortable, relaxed position. If I draw a straight line down my forearm and continue it on, you can see the head of the needle holder is quite a long way off that straight line. Now, what do we do with a needle holder? Well, basically, we're trying to turn a needle, aren't we, around the radius of the needle that we've got. And so if you imagine doing that and actually not doing anything with the wrist, what will happen is if I just turn my forearm, the needle holder head takes a very wide arc. So when we're using a needle in this particular grip, what we'll end up having to do is actually doing some flexion and extension of the wrist to keep the needle holder head where we want it. So sometimes if we're using longish needle holders, or we've got small needles, or we're doing some delicate work, we palm the needle holder off. So we drop it out of one or both of the rings. So one thing we'll quite commonly do is drop the thumb out and take the thumb down the instrument, and we stick the thumb ring on this fleshy piece of the thumb, which is called the thenar eminence, and we can open and close the instrument in that position, because I can push this way with my thumb to open the instrument, and I can close it just by bringing the thumb back together, and the ratchet will close it. So I can open and close the instrument without my thumb in the thumb ring. Okay, or alternatively, we can drop the whole lot out. And dropping the whole lot out means that I can now make the needle holder run down the long axis of my arm, absolute straight line. So now if I want to do this pronation supination, all I've got to do is rotate my forearm. My wrist has got to do much less work to keep the needle holder head just running around the radius of the needle. So if we're doing delicate fine work with a small needle, I'll nearly always palm the needle holder off, because it's just going to be so much easier and more comfortable to do that procedure with the instrument palmed off. So that's what we'll do. We'll palm it off. So what is it that we do? Well, it's a pronation, what's called a pronation supination. So in this position, my hand is prone and in this position my hand is supine. So if I go from supine to prone, that's pronation. And if I go from prone to supine, that's supination. So that's what we're doing to turn the needle around. Okay, so that's some needle holders. What about thumb forceps? Well, there's a balance point to thumb forceps. So there's a center of gravity. So if I balance these thumb forceps on my finger, so it's a bit like a seesaw, that's the center of gravity for these thumb forceps. So that's really where I want to try and pick them up. So they're not trying to push down at the back end because they're heavy, and they're not trying to push down at the front end because they're front heavy. They're balanced. So there's my point where I want to pick them up. So I'm normally going to have them in my left hand, my non-dominant hand. So my thumb comes across to where that center of gravity was, and on the opposite side, my index finger and my middle finger positioned opposite, so that the thumb is at that pivot point. So that means at that point is the instrument's balanced. It's not trying to fall down this end, and it's not trying to fall down that end. It's balanced. So if I then move my middle finger or my index finger, I can rotate the instrument around the pivot point, the fulcrum of the center of gravity, which is the thumb, because that's where I positioned it. So I can move the instrument in this arc. If I turn it the other way, if I bring those fingers in and out, I can move the instrument in the opposite plane. And so as a combination, I can spin the instrument either way. My thumb's doing nothing. It's just at that fulcrum. It's my index finger, my middle finger that are doing the work. So I've got really good control over them. And again, they're on the tips of my fingers, aren't they? So I've got really good feedback. Don't really want to do is a power grip, because a power grip, you've lost that feedback, and also your hand gets in the way. So when you're working down, in an abdomen, for example, or maybe a thorax, your hand gets in your visual field much more readily. So it's much more difficult to see exactly what you're doing. And clearly you haven't quite got the feedback that you wanted from the fingertips. So we'll normally work with tissue forceps in this grip that I've shown you. Okay. And then scalpel handle, well, we'll normally pick that up as a pen holder grip. So that's a bit like you're writing a letter, for example, with a pen. And that in that particular grip, as I've got it held here, let me just come in a bit closer so you can see it. I've got it so that my middle fingers are below it, and my index fingers are top, and that's got means that again I can just move it in that direction. That's all that's happening. I'm doing nothing with the wrist; it's just my fingers that are using that. But I can also spin the thing down its long axis. So again, if I wanted to do a curvy linear incision, that's what I can do either way. So that's called a pen holder grip. The other grip that we sometimes use for a scalpel blade is often what's called a power grip. The problem with a pen holder grip is if you're cutting onto something that's very, let's say, collagenous, so the skin, for example, and you're pushing quite hard, there's a possibility that the scalpel might slide, and therefore you've not less got control. You might be fingers might get close to the blade. In which case, we'll often put it into a power grip, so it'll go into the palm of the hand, and we've got a much better way of pushing hard. But in the power grip, we've got less ability to move the scalpel like we would have done if it was in the pen holder grip. But often you'll just convert between the two, and you probably won't even know you're doing it. And one other thing just to note about a scalpel holder, it might be worth you having a look in the scalpel blades that holders that you've got in your practice, is that you can buy them with scales on the back. So this has got a centimetre scale on the back. So that means that in every surgical set that you've got, in this case, a 5.5 centimetre scale. So if you're doing any oncological work, for example, you've always got in your kit a sterile scale if you want to measure margins, for example, if you're doing some form of excision of a tumour. Okay. And then the last thing, just to bear in mind, is this palming off thing that I was talking to you about with scissors. Just move on to scissors. So as a single-handed surgeon, If you happen to be using a pair of needle holders that are without scissors, so you can obviously buy needle holders that come with scissors within the head. So these are Olson Hagar needle holders. But if you're using standard needle holders, when you're tying a knot, you've got to put the suture down. So you tie your knot. Let me just get something to show you. So you tie your knot. Let me just put this through. Here's the suture going through. And you pull it down, you tie the knot. Okay, so there's the knot tied. And now I need to cut it. So what am I going to do? I'm going to put these down. I'm then going to go and find the scissors, pick the scissors up, pick the suture up, either cut it individually, which is not ideal, or put them into the same hand, and then cut. Put the scissors down, pick the needle holders up. So there's a lot of action going on there that is not particularly efficient. So as a single-handed surgeon, which we often are in veterinary practice because we often don't have an assistant, maybe we can think about palming the scissors off. So when we're talking about palming off needle holders, for example, it's an action where we're bringing them into play, so they're in play, and then we're going to use the index finger and maybe the middle finger to bring them out of play and put them into the palm. So in the palm, it leaves you free with an index finger, thumb, and middle finger. And you can do most things with those 3 digits. When I want the needle holders back, I bring them back into play with the little finger, and the back where I want them to be, either I can have the ring out of the thumb or put the thumb back into the ring. So palming off. So it takes a bit of practice just to get used to being able to move the instrument in and out efficiently. What you're not doing is flicking it. You're not trying to flick it in and out. You're trying to move it in and out with the fingers of your hand. So little finger, middle finger, or index finger to bring it in and out. Okay? So that in itself is quite a useful thing to be able to do. I put the scissors into there and do the same thing. So sometimes it's a bit more awkward to do it with scissors just because they have a tendency to separate. If they're not fixed, they sometimes open up when you're trying to flick them, which is very irritating. But you can sometimes stop that happening by putting your little finger into that ring and using that to bring them round, and also having that there to lock them off. So there's the scissors in the same action, and now I put the needle holder back where it was. Okay, so I'm going to palm off the scissors, put the needle holder back in, and then I can do everything. It doesn't really feel like I've got any scissors there. So let's do the same thing. Here's the thing that we're going to put the suture through. Turn the needle out, take it through. Put my knot on here. Make sure it's lying squarely. But this time what I'm going to do is bring the 2 threads across, take them into my left hand, then bring the needle holder in, clamp the 2 ends, take the needle holder into my left hand, my non-dominant hand. I'm going to then bring the scissors into play, cut the suture, take the scissors out of play again, palm them off, replace the needle holder, and off I go again. So it's just much more efficient. It means that you can tie a knot, bring the scissors in, cut, take the scissors out, away you go. Bring the scissors in, cut, take them out, and away you go. That takes some practice to get good at it, but if you master it as a single-handed surgeon, I think you will find that as a really useful tip and trick that's going to make your life slightly easier, and certainly your suturing slightly more efficient in terms of what you're actually trying to do. Okay, let's just move on and talk very briefly about some sutures and just try and get some understanding, especially around half curved and curved sutures. So in your practice situation, you'll probably be aware that there are so many different suture types available for us, all packeted sutures, and you may well be using some packeted and some cassette suture material. But sutures seem to really confuse people often because I think there's so many of them available. But I'm just going to concentrate on a few things about them that might make life slightly easier for you, or you might be able to do these things and it might make life slightly easier for you. We're going to talk a little bit about needles, and we're going to talk a little bit about one of the things that modern monofilament suture materials will allow us to do. So let's just talk a little bit about the needles. So most of the modern suture material packets that you have will have one-to-one representation of the needle that's in the packet on them. So this is a one-to-one representation of the needles, in this case, needles that are on this suture material. So I would say that it's not uncommon if you're in a practice situation and you happen to have, for example, more than one needle suture combination of, let's say in this instance, 2,0-proline, polypropylene. You ask the nurse, the circulating nurse, whether they can provide you with some 2,0-proline for the procedure that you're doing. And sometimes they don't necessarily realize that there may be more than one suture needle combination. And so they then open the correct size suture, but with the wrong needle on it. Well, that's quite an expensive thing to do because these packets of suture material are not going to be cheap. They're going to be, a reasonable amount of money, and certainly something you don't necessarily particularly want to waste. So always have a look, because remembering codes is nigh on impossible. The codes are very confusing for most of the packaged suture materials that we see. The codes that they come up with are very difficult to work out as to exactly what it is that you're actually trying to use. Let me just get another one out as well. Codes are very difficult to understand, and often you can't remember them. The other thing is that we generally work with probably, I suppose, 3 commonish needle types. One will be a taper. So let me just come out a little bit so you can get a better look at these, and I'll maybe go in and just organize them into some system so you can see them. So there's a range there. These are all what's called taper point. Okay. That basically means you're talking about a needle. Okay, so that's all it is. It's the needle coming to a very sharp point. I mean, this is probably a good example of looking at it. So most of them will show you the needle, but they'll also give you an idea of what the needle looks like if you look onto it straight on. So if it was looking straight at you, what does the tip look like? So that's what a taper is going to look like. And here's an example of it coming to a tiny pinpoint end. So these are atraumatic in terms of what they're going to do to the tissues that they're going to be passed through. But they probably have a tendency to become blunt, probably quicker than something like a cutting needle, especially if you're going to be putting them through tissue that's quite collagenous, so the skin, for example, or the subcuticular space. So they're not going to be very good for that. So there are other options. And the other complete opposite end of that would be a cutting needle. So here's an example of a cutting needle. Here's another one, and here's another one. And so these are all cutting needles. And these have got often or mostly 3 sharp edges, which are scalpel sharp edges. And the edges are wider than the body of the needle. So these are going to be relatively traumatic when you're putting them through. And we would normally restrict these for a time and a place when they're required. So most commonly, that will be the skin, or if you're putting them in the intradermal or subcuticular space. But there is, again, a sort of halfway house, which is a needle I quite like. And there's a lot of personal preference to these things. So this is just a needle I particularly like, but it's as I say, it's a personal preference thing. Just find some examples of it. So there's some examples of it. Different manufacturers might call them slightly different things. But basically, this is often called a taper cut or a taper point needle. So if I just come in and show it you, so there's an example of it. So this has got a three-sided cutting edge point, but the width of the point with the cutting edges is never wider than the body of the needle, and therefore, although it's got a very sharp point to it, which probably stays sharper in my experience than the most taper point needles, although that's probably debatable and some of you may disagree with that, it's not going to be traumatic. So for me, this is sort of a go-to needle. I quite like this needle because I think you can use it in most circumstances through most tissues, and it will work effectively and will stay sharp for me longer than others that do. I'm not going to be using it necessarily on the skin, but because I'll be using a cutting needle for that. But as my sort of go-to needle for lots of tissues beneath the skin, I quite like the taper cut. But as I say, there's personal preference to those things. So don't get me wrong. You may disagree, and that's absolutely fine. You may have a preference for something different. So that's some needle points. The most common shapes to the needles that we're going to use, we're either going to be talking about half curved. So let's just get that into focus. There's a half curved needle, or a 3/8 needle. So here's a 3/8. So that basically means that for a 3/8 needle, 3/8 of the circumference of a circle is made up of needle. The rest of the circumference is there's nothing there. It's air. Half curved, half of the circumference of a circle is needle. The remaining half, there's nothing there. So what's the difference between these two? Why do we have them? Well, we need to just talk a little bit, or at least understand maybe one thing about needles, and that's a term called the chord. So if I just show you a diagram of a needle. So here's a diagram of a needle. Here's the point, and here's the swage where the needle attaches to the suture material. The distance between the point and the swage is called the chord. Now, if the needle was a half-curved needle, the chord of a half-curved needle will be the diameter. But if the needle is a 3/8 needle, it won't be the diameter, will it? It's going to be slightly less than the diameter. Okay? So what's that all about? Why do we worry about it? Well, a 3/8 needle is going to take you slightly less work to place it, isn't it? Your pronation supination for a 3/8 needle will probably be less, or maybe the other way of looking at it is it will be more if it's a half curve, because you've got to take it all the way around the half curve. Okay? So when will we pick one over the other? Well, let's take this 3/8 needle out and just have a look at it. Here's the suture material. Here it's coming out of its packet. One other thing I can just mention when I do it. So this suture material has come out of its packet, and it still looks like it's called up in the packet, doesn't it? Okay, that's called memory. And so different materials will have different memories. Generally, monofilaments will have more memory than braideds, but often we can try and get rid of that memory by just grasping the suture material near the needle, not on the needle, near the needle. I don't want to pull the needle off. Taking the opposite end, and if I keep my left hand fixed so it's not moving, and now I can stretch the suture material. So this has got considerable. It's got nearly 5-6 centimeters worth of stretch and then elastic recoil. Okay, but if I stretch it quite vigorously and now put it back down, it's changed its shape. That's called plasticity. And now in this form, it's going to be much easier to use than it was when it first came out of the packet. Okay, so let's go back to the needle. So you might want to try that with lots of materials. And so if you haven't tried that with the materials that you've got in the practice, maybe have a little look at the materials that you're using and see what they actually do. Okay, so here's the needle. It's in the needle holder. Needles that we use generally will be flattened in this last little bit down here, this last third at least, especially on the inner surface, and they're flattened slightly. So when you put them into the needle holder and you click the ratchet, the needle is held. It won't rotate around its long axis. So the needle is being held by the needle holder. I'm not doing anything to hold it. The needle's being held by the needle holder. So all I've got to do is to turn it around its circumference. Okay, so that's really helpful. If the needle was round, completely round, it would spin in the needle holder head and would actually be quite awkward to use. And you've probably experienced that if you've ever used any needles that are separate and you're putting onto cassetted suture material. The round body ones of those often are truly round bodies, and they will spin in the needle holder, and it becomes quite irritating. Okay, let's go back to this 3/8 needle thing. Let's just bring the camera in. Okay, a 3/8 needle, the material that you're putting in the needle and the bite needs to be equal or less than the chord of the needle that you've got in front of you. Okay, so if it's less than the chord, so let's say it's going to go across there, that's less than the chord. If I stick the needle in, generally goes in perpendicular to the structure that you're going to suture. Let me just turn it through and out. I'm going to see the tip of the needle. Okay, and then I can take the tip and turn it all the way through. If I try and put the needle through something that is wider than the chord of the needle, so let's just see if I can get this to show on the screen so you can see it. A 3/8 needle, I don't ever see it again. Come up to the swage and I've lost the needle. It's not come back out again. So there's no point using a 3/8 needle when you're trying to put the needle through something that is bigger, wider than the chord of the needle. But it's perfect for things like the skin, because the skin is obviously very thin, so I can pick the skin edge up and put the needle through. And because it's only a 3/8 needle, I have to do very little pronation, supination to turn the needle and re-grasp it to turn it out. Okay. The half curved, on the other hand, hopefully will have enough of a curvature to it that should I want to put it through something, it's just going to let it focus, which is wider than the chord of the needle, hopefully, as I take the needle through, as I just get to the swage, I can see the tip of the needle and I can bring it back out. Okay, so there's a time and a place for needles, and there's really no point using a half curve needle on something like the skin, because although you can use it for that, here we go, here it's coming through and out, I have got to do a much greater supination, pronation to turn that half curve needle out. And if I don't do that properly, if I don't do that properly and completely, I will end up forcing the needle off its radius of curvature. And if I force it off its radius of curvature, that is when we're likely to bend the needle. Okay. Okay, I'll show you one more thing with suture material, and then I'll show you a modified miller's knot for ligating pedicles. Okay. So I think lots of you, if you were closing skin up tomorrow, will probably be putting on a surgeon's knot. So here's my suture gone through the skin. What I'm saying is that because there's a little bit of lateral tension on this, if I put a single throw on it, take it down, I can set the tension, appositional. If I let go, it loosens, doesn't it? Okay, because it's one, because there's some memory to the suture material, so it wants to go back to its original shape. And 2, because there's just a little bit of lateral tension on it. Mostly that's come undone because of the slight memory that's in the suture material. So I guess for lots of you, you're going to put 2 throws on, aren't you? There's 2 throws. There's the surgeons. And that's probably going to hold. But we produce an asymmetrical knot. So what I want to show you is that modern monofilament suture materials will allow you to set the tension very accurately. On the skin, it may not be the most useful thing to do, but when you're doing things like bowel surgery or delicate surgery on things like the bladder, for example, and you're just trying to produce very neat apposition, this can be a really useful trick. So I'm going to put a single throw on. There's a single throw, and I'm going to purposely make it really loose, just so I can prove a point to you. Okay, here's the second throw, and this needs to be put on absolutely squarely. So you can see that's a square. I'm keeping equal tension on both sides of the suture. That won't lock. It will slide down, and I can set it to the perfect tension that I want. Then I can let go, and then I can put the third throw on, and this will be a lock stitch. So if I keep this completely square, I can pull that as tight as I want, and it won't tighten that knot up anymore. It will stay as it is. And here's the fourth. Okay, so that is with modern monofilament suture materials a really, really useful way of being able to tie knots and exactly the right tension. Some people have real problems tying the right tension on a cruciate, for example. So here's a cruciate pattern going in. Let's just put the suture across, turn it out. Let's just put it in again just to show you one cruciate and show you the same thing. So here's my cruciate. Just pull it down so it's about right. Let's get it back into the screen center. Okay, so lots of people find it really hard to set the right tension on cruciates. They're either too tight or too loose. But if you do what I've just shown you and to put a single throw on it, there's a single throw, there's a second throw, keep it completely square, I can set that tension absolutely perfectly and then let go and put the third stitch on. Now this is going to require monofilament suture materials. If you're using something like a pseudo monofilament suture material or a pseudo multifilament suture material rather for the skin, you might find it locks and so it won't do that. But modern monofilament suture materials will generally do that really effectively, and it's a really neat way of being able to set the tension correctly on the structure that you're trying to ligate. Okay, so I'm just going to now just finish off by just showing you the modified Miller's knot, and let's just move some of these bits out of the way and just bring in the suture board again. I'll just drop this out. Quick clear up. When we're ligating pedicles, so classically when we're doing an ovarian hysterectomy, that's probably the one that people probably panic about the most. We have this problem that we can tie the thing tight enough and stop it bleeding, but between the first and the second throw, it can come undone. So what I basically mean is, if we've got a pedicle and we're trying to ligate the blood vessels that are in it, there's no doubt that we're all capable of pulling this first throw tight enough to occluding the blood vessels. But what often happens, and we're often doing this with an instrument, is that we've pulled it down tight, and then when we let go with the instrument to put the second throw on, we don't know what's happening with this first throw, and it could be loosening. Hence, we then get a ligature that doesn't seal, and we can get hemorrhage afterwards. So the ways round that we've got, well, one of the classic ways around it, obviously, is to put a surgeon's throw on it. So there's the suture around the pedicle, and what we're going to do is put a surgeon's throw on, and then do the same thing. And what we're hoping is that the 2 throws, because there's more twist around the suture, there's more friction there, and therefore it's less likely to loosen between the first and the second throw. Still might do. If you can't remember how to do a modified Miller's knot at the end of this, one thing that you can do is just go round the pedicle twice. So that's round the pedicle twice, and then put on whatever knot that you want to put on. It's probably going to be a surgeon's knot, isn't it? So here's a two throws of the surgeon's knot. And again, all that's doing is putting more suture material in contact with each other, and therefore there's more friction, and therefore you're hoping it's less likely to loosen between the first and the second throw. But what we could really do with is coming up with a knot that in essence looks a bit like this. So we've got the first throw, and part of the knot is actually another piece of the suture that's sat on top of the first throw, pushing on the first throw, so making that less likely to come down. So it's a bit like you pulling on this and having somebody put their finger on it, so that between the first and second throw, the finger is stopping that loosening. That's what we're sort of trying to achieve. And that's what in the UK we'll commonly call the modified Miller's knot. Sometimes it's called a Miller's knot. It depends. There's lots of problems with the naming of these knots, and there are lots of different ways of tying a modified Miller's knot or a Miller's knot. And so some people now call them strangle knots or constrictor knots. In the UK, we generally call the knot that I'm going to show you a modified Miller's knot, but on the internet you might well find this as a Miller's knot. The way that it's often shown on the internet is I'll show you two ways to tie it. The way on the internet that's often shown is this first way. So as a right-handed surgeon, I've got the suture in my left hand and I've got needle holders in my right hand. So the suture is going to come from the near side. Mostly we want to go from the far side to the near side, but we're going to go the wrong way. I think you might prefer the second way that I'm going to show you how to do this. But we'll do it this way first, because this is often what you'll see on the internet. So we come under, over, under, over. And basically, I've worked from left to right. All I've done is gone round, round. Okay? I've got the long end just in the palm, held by my ring finger, little finger, and I've got the short end held between my index finger and my thumb. If I then take my hand and sort of open it up, taking it towards that left-hand side, I can then see one loop. Got one loop going round. So my needle holder comes in from the right-hand side. It goes through the one loop, and it sits between the two threads. It doesn't sit on the outside of the short end, and it doesn't sit on the outside of the long end. It sits between the two. And then I'm going to put the throw on the suture. So the needle holder goes slightly away from me and then towards me, around the long end, and takes the short end. And then at that point, I'm going to pull the short end towards me, take it down. So if you look, there's the throw that I've just put on it. And here's this piece of suture that's going to sit on top. Let me just come in a bit closer so you can see. So there's the throw, and there's the suture that sits on top. So the tighter I pull it, the more this outer suture is pushing on the throw. Okay? So that's the modified Miller's knot. I'll show you again. And you could just make a modification to that and put two throws on it, and I'll show you that as well. I'll just show you right from the right hand and the left hand. I'll show you again from using it as if you're a right-handed surgeon. Under, over, under, over. And I've got the short end held between my index finger and my thumb. And the long end is just held down here with my, in this case, middle finger, ring finger, and little finger. Take them all across. One loop, needle holder through the loop, and I'm going to go round the long end. Okay, I could put two throws on it. So I could put a surgeon's on it. 1, 2, and take. Okay, might give it even a bit more security, but often, well, don't really need to do it, I don't think. Mostly just one will do. Okay, so here's the one. One throw, take, pull towards, and that's the modified Miller's knot. So it's the first throw. You're then going to put square throws on top, okay? Just like you would if it was a surgeon's knot. It's just that first throw. Let's just do it with the left hand for the left-handed people amongst you. Let me just show you that. So just swapped hands. Now I'm going to pretend I'm a left-handed surgeon. So I'm going to come under, over, under, over. And I've got it held. This time the suture's coming in, middle finger, ring finger, little finger. Take the short end between my index finger and my thumb. Open my hand up. Here's the loop. Needle holder goes between the loop, sits between the long end and the short end, goes around the long end, takes the short end and pulls it towards me. And there's the modified Millers. Okay. So let me just show you the other way of doing it, which you might find more straightforward. So this time we're going to go from our preferred side. We're going to go the far side to the near side. So the suture's coming in. And what I'm going to do is include my index finger and my middle finger in the loops as I go round. So that's gone around once. That's gone round twice. And it's not just gone round the pedicle. It's gone round my index finger and my middle finger. Now when I get to here, I take the short end up, goes beyond those two, and I can just clamp it there, if I like, with my thumb. And then the instrument comes between the two loops that I've made, grasps the short end, pulls it through. There's the throw. And that's it tightened down. I'll show you that again. I'll just do it slightly closer up. And then I think we'll probably finish after this one, just looking at the time, if that's okay. So let me show you that again. Over, under, over, under. And then the short end's going to come across the top. Instrument comes between the two loops. Grasp the short end, back through. So actually, it's just reversed the knot round compared to how we did it the original way round. Okay, looking at the clock, I think that's probably a reasonable time to stop at that point. Has anybody got any questions? Daniela, have you seen any other questions or any questions come through? I'm not quite sure if Danielle is still there at the present time. There's Paolo there. There's Danielle. Brilliant.
Here I am. Hello. So because we need to give a little bit of time to people to ask questions. First of all, Rob, I would like to thank you because this was really an excellent presentation. In fact, we have, I guess you can read the comment of Dr. Cristina Diaz.
Yeah, that's very kind. Thank you very much.
Yeah, about the really usefulness of the basic skills for everyone. So whilst you were talking, I was doing the exercises as well, because even if I have a lot of experience, in the end, sometimes it's easier and quickest to do knots in our own manner instead of following the precise technique. So what you have showed us, Rob, is not only important for students and junior vets, but I think also for some of the senior vets is really a very important refresh that you have given us, and I'm very grateful for that. I was just wondering whether, whilst you were showing how to handle the scissors and the needle holders, when you were, for people that are operating on their own, where you were alternating the needle holder and the scissors to cut the sutures, would it be possible to show it once again, because it was not. You need to zoom out a little bit so that we can see better how you do the swap between instruments.
Let me just get the screen back. Let me just get something to stitch. Hang on a sec. Some scissors. So basically, the scissors go into first, and they're going to go straight into your tripod grip. Let's get some suture material handy so I can just stitch something. That's fine. So they're going to sit in the tripod grip, and somehow you've got to just be able to learn how to bring them back in and out. And you don't need to do it in a fancy way, so you can do it in a quite controlled way like that. So some people, will get very good and they can flick them, but getting the flick right is sometimes quite difficult to do with scissors, because they often have a tendency to open up, especially if they're older scissors. They don't stay closed. So it doesn't really matter, whether you do that in an elegant way or whether you do it in a more slower way than that. Basically, that's what you're doing. So the scissors are going on to that ring finger first. They then come down into this palmed off position, and sometimes putting your little finger through the other ring, especially if they're scissors that have a tendency to open up. I mean, these ones don't. They're quite nice. They stay closed. But if they're an older pair that open up, you can just put the little finger in. They're then out of the way. So then you're going to put the needle holder in as a normal. So here's your standard tripod grip with the needle holder. So then I can do everything with the needle holder that I was doing before. I've just got the scissors palmed off. Then I can take the suture and I can tie my knot. So here's the suture, here's the board, take the suture through, tie whatever it is that I'm suturing up. And then what I do is I take both threads across to my left hand. I then clamp the suture just near where I'm going to cut it with the instrument. Take the instrument, the needle holder, into my left hand. The scissors then palmed off, they come into play. I can then cut the suture. So I'm cutting both in one go, so it's actually quite nice because it just gets them all out of the way. Scissors go back into the palm, needle holder goes back, and I can then carry on. Is that clearer, Daniela?
Yes, very clear. Yeah. Fantastic. So we are just waiting for questions. So we have this lovely message again from a LinkedIn user that they would like to show this video to junior vets. So just to remind to everyone, this was our live, but if you have missed the live, you can see the webinars of Professor White more times, as many times you wish, because there will be the recording on the Vets on Air Facebook page, as well as for all the other webinars that we have already had and we will have in the future. So here is a comment from Vicky. Hi, Vicky. Question for you, Rob.
Yeah, I'm just reading it. So, yeah, the two systems. I tend to find that most of the places I work use what's called the United States Pharmacopoeia system. So basically, there are two systems that we use for sizing suture material. There's a European metric system or European pharmacopoeia system. So that's a metric measurement. Or there's the United States Pharmacopoeia system, which is the 3.0 or 4.0, whatever it might be. And they're basically just two different ways. They're not quite looking at the same thing. The metric system is related to the diameter of the suture material. And so 2 metric, the suture material is 0.2 of a millimeter in diameter. The United States pharmacopoeia is more to do with the tensile strength, and so the two aren't necessarily completely compatible. It happens that mostly they are across the ranges of suture materials that we use, but they're not entirely. And what happened with the United States pharmacopoeia is that when they first started sizing suture materials, they called the first one 0, and they could make suture materials that were bigger. So the next size up in tensile strength was 1, and then 2, and then 3, and then 4, for example. When they could start making suture materials smaller, because the manufacturing process allowed that, they didn't really know what to call them. So they called them the next size down 0, 0, the next size down from that 0, 0, 0. Well, obviously it starts to become a mouthful, considering sutures go down to 11 zeros. So that's where you get the 2, 0, 3, 0, 4, 0. And so the smaller the size with the United States pharmacopoeia system, the bigger the first number might be. So 5, 0 has got less tensile strength and will be thinner in diameter than 4, 0 or 3, 0 or 2, 0, if that makes sense. Yes, it is irritating, and different people use different systems. I guess I'm more comfortable with the United States pharmacopoeia. It's the biggest number that's on the packet, and so most of the places I go, that's what they'll understand. But I've certainly worked with colleagues who are more up to date than me and use the metric system, and that's fine. It's just sometimes it gets a bit confusing if you're trying to use both. But they are slightly different things. That's the only thing to remember. They're not entirely looking at the same actual value. One's to do with tensile strength and one's to do with diameter.
So we have a nice comment, lovely comment by Erika Sampaio. I might have a question, or maybe it's more than a question, is maybe a comment on, you were describing the different type of needles, so 380 or and you were talking about the round needles or the cutting needles. I'm not sure, maybe I've missed. So would you be happy to reiterate when we should use the round needles and when we should use the cutting needles in which procedures?
So, yeah, I mean, it really just depends on what you're putting the needle through realistically, and also whether you're prepared to damage it. So a cutting needle will predominantly be used on the skin or in the subcuticular or intradermal space. It's a tissue with high collagen, and therefore it needs something that's going to be fairly sharp to go through it fairly cleanly and not go blunt. I mean, you could use a cutting needle in other circumstances, but if you do, and let's say, for example, you used it on some small intestine or some bladder, because the cutting edges are wider than the body of the needle, they're quite traumatic and they're going to make quite a big hole. And if you make quite a big hole, it could leak. So the suture won't plug the hole that you're putting the needle through. So we'll generally use a needle that's not got a cutting point when we're going through something like that. And at that point, you've got a choice. Most people will generally use what's called a taper point, and that's just like a needle. So that's going to hopefully pass through those structures fairly easily, but it's not going to produce a big hole. The hole's going to be the same size as the needle diameter, and therefore that's going to be not far off the same size as the suture material itself. So hopefully it won't leak. The last one I showed you was this sort of halfway house one, which sometimes called a taper cut, or sometimes called a taper point. And the tip of that needle has got 3 cutting edges to it, but those cutting edges are never wider than the body of the needle. So potentially it stays slightly sharper than a taper point needle, but you could use it in all of the same places as a taper point needle. It just may stay slightly sharper, but it's not also going to be traumatic. It's not going to produce a bigger hole. So some of it comes down to how many suture needle combinations you have in a practice. So one of the problems in general practice, for sure, is that the cost of these materials is quite high, and therefore you're always looking for the ideal suture needle combination that will do as many things as possible within your surgical caseload. And that's why, for me, I quite like the taper cut needle because I think it's potentially usable in maybe more circumstances than a taper point. And for me, I find it stays slightly sharper, if that makes sense. So yeah, if you had endless money and endless budget, you could get the correct suture needle combination, but you'd end up having lots of different packets of suture that would be sat on a shelf that may actually end up going out of date, for example. So that's always what we're trying to do is trying to find this ideal suture needle combination that we can use for as many procedures as possible. I don't know if that answers your question, Daniela, or not.
Absolutely. Rob, we have another question by Fabio Esposito.
So yeah, the slip knot thing. So what you're saying, I'm just going to share the camera. We steer clear of this a bit with the students. They do get talked about it, but I'll explain what I think you mean. I'm not. There's nothing wrong with it. You've just got to be aware of what you're actually doing. What I think you're saying is that if you have a square knot, you can turn it into 2 half hitches if you keep tension on one side. So here's the suture gone through the material. Here's the first throw. If I keep equal tension on both sides, it stays as a square throw, doesn't it? We're just going a bit closer still so you can see it. But if I don't do that, if I pull on one side, it converts itself into, I don't know if you can see that, a half hitch. Okay, so that basically is you can see the twist. There's the half hitch, there's the square. So if I put 2 throws on it and do exactly the same, pull preferentially on one end, which is normally going to be the long end, it's converted itself into 2 half hitches. Now that's going to slip. That will slide down, but at the moment it's still 2 half hitches. So I've got to be really careful now, because what I've got to do is come back across and hope if I pull it tight enough, it will convert itself back to a square knot. So that's what I think you're describing. There's absolutely nothing wrong with it. You've just got to be really conscious that you do that. And one of the things that we're not very good at is tying knots, if you see what I mean. And so we have this tendency to tie things really quickly. And if you tie things really quickly and keep preferentially tension on this long end, which is often what we do, all of these throws that I'm putting down at the moment are all going down as half hitches. Now it looks like they're being tied correctly, but if I could show you that in close-up, you would see that all of the knots down here, I don't know if I can't get in close to that, are going down as half hitches. So you've just got to be very careful. I think that's what you're describing, and I think that's what you mean by it, is you're sliding those first 2 throws down because it's a slip knot, and then you're converting it back into a square knot. We generally are a bit wary of that, especially with the undergraduates, just because it might get them into a habit of not realizing that they're not producing a square knot, if you see what I mean. Does that answer that question?
I think so. So we have Petra. Hi, Petra.
Very kind.
Sure, I would have liked to have it as well when I was a student. Yeah, absolutely. Rob, I have another question, if you don't mind, about, because you have mentioned, as you were talking at some point, you mentioned, this suture has memory. So would you be happy to remind to people, the people that are listening to us, what you mean with the memory of a suture material, please?
Yeah, let me just try and find something that's got high memory on here. This has probably got the highest memory. Let me just come off the screen again. Hang on a sec.
Yep.
Let's go back to camera. So the memory of a suture material is its wish to go to remain in the shape it is. So if you take out of a packet something that's a braided suture material, so here's an example of a braided suture material. So this is Polysorb. this is lots of fibers of suture material that are braided together to produce the material. So another example of that would be Vicryl. I don't know what I've done with my Vicryl. Anyway, there's the packet. So same sort of story. And then from a B-Brawn product, which would be something like Novacin, they're braided. So they're a bit like a wick. So they have very little memory. They're soft, a bit like a cord or a shoelace or a piece of string. And so they have very low memory. The downside to them is because they're multi-filament and braided, they have a very large surface area. So you don't want to be putting them through the wall of a viscous full thickness, for example, because they could track luminal contents. For example, if it was the bowel contents, through the site of the incision, you can end up with an abscess infection outside the luminal structure that you put together. But they have very little memory. So when they're liked by people when they come to tying knots, because you feel like they're nice and easy to use. Memory is the thing that makes the suture material want to stay in the same shape that it was when it was manufactured. So here's an example of a polypropylene containing suture material. And I suspect if I take this out of its packet, it's going to have reasonably high memory. So it looks like it wants to be in the same shape it was when it's around the cassette that it was within the spool. And here's another example of a polypropylene suture from Ethicon. If I take this out, same thing. Okay, high memory. It's trying to stay in the same shape. And so when you try knots in a material like this, so this is normally a monofilament suture material, and polypropylene is probably the one that you're going to be using if you're using it in practice, the one that you're most likely to come across in general practice. It means that the knots that you tie, the suture material is trying to undo the knots. It wants to go back to its original shape as it is now. Now that means that monofilament suture materials get bad press because people say they're very difficult to tie knots with. Modern monofilament suture materials have been designed to have ability to mean that the memory is much less. So this is polydioxanone. This is Ethicon's polydioxanone. So this is PDS. So again, this is a monofilament suture material, but I take it out of the packet and you can instantly see it's not got the same degree of memory as the polypropylene has that's down here. It's got some memory, isn't it? It's still staying in that shape. But you can try and get rid of some of the memory or make it more, that's the wrong term. You can make it more easy to use these products with memory if you try to see if you can change their shape, and that's called plasticity. So for example, with this polydioxanone, if I grasp the suture material near the needle, not on the needle, because I might pull the needle off, but near the needle, and take the opposite end, and I keep my right hand fixed, you can't see it, it's off the screen, but it's fixed on the tabletop. There's a huge amount of elasticity to this material. So this is this polydioxanone. I can stretch it, and when I let go, it comes back. So it's got elasticity, okay? But also, if I now have a look and see what I've done, it's now straight compared to what it was before. So I've altered its shape. So that's plasticity. And I'm going to find it easy to use now it's straight. And certainly these ones, in their current shape, are going to be really difficult to use. So if I do the same with this is Ethicon's polypropylenes. So this is Proline. I'll do the same. Again, it's not got quite as much elasticity. It's got good elastic recoil. But again, it's got plasticity to it. I've now changed its shape and made it straighter, and it's going to be easier to use. In something like the polypropylene, the polydioxanone, this elasticity of modern monofilament materials is there for a reason. It means that when you're tying a knot, you stretch the suture material with the elasticity that it's got. And when you let go to put the next throw on, there's elastic recoil. So the throw tightens up. So each time you're putting a throw on a knot and pulling it tightly, you're stretching the material and when you let go, it's got elastic recoil, and the elastic recoil is one of the reasons it's keeping the knot secure. So those products, that physical characteristic of these materials has been purposely built into those materials. If you pick up something like a multi-filament suture material, like Vicryl or the Polysorb that I showed you, this has got hardly any elasticity to it at all. That's me doing exactly the same. My left hand's fixed and I'm pulling on material. Hardly any elasticity or elastic recoil. It doesn't need it because it's multi-filament, and therefore it's likely to tie reasonably secure knots on its own, if that makes sense. I don't know whether that helped and or answered the question.
I think absolutely helps, even because the next question would be, considering the memory, the elasticity and the plasticity. So would you, because most of us use always monofilament sutures and instead of multi-filament braided suture materials, but for example, are there particular situations where you would use the multi-filament braided suture material?
So I think this is personal choice nowadays, because when I'm just going to show my age now, I'm afraid, but when I was qualifying, I qualified in '89. Modern suture materials had only really been around for 10, 15 years maybe, and there was nowhere near the range that there was nowadays. And so there was a material that was a multi-filament material that was called Dexon, and that was a material that was not dissimilar to Ethicon's Glycoma 910, which was Vicryl, but Vicryl came out later, and so they were like the wonder suture materials. They were absorbable, and they were absorbed relatively quickly, and they were considered useful in all sorts of places where we wouldn't nowadays probably use them. And so my generation used things like Dexon and things like Vicryl, and would be the same as the Polysorb from Covidian, for example, for lots of things that I think generations of students coming out nowadays wouldn't. So I used them quite commonly for pedicle ligation, for things like ovarian hysterectomy, because we were always told tied very nice knots. People still sometimes use them for linear elbows, which is a bit of a nightmare because it doesn't really provide wound support for long enough for things like the linear elbow, but people get away with it. The problem with them is the wicking aspect, and the fact that if you put it through anything that's got infection in there, it's going to cause problems. And also, if you put it in subcuticular space, it has a tendency to erode through the skin. And also, all of those multifilaments that are made from things like Glycoma 910 and similar products tend to produce quite a marked inflammatory response, a sterile inflammatory response to their hydrolysis, their absorption. So they're probably not very good for subcutaneous closure in things like cats, especially. See it in dogs, but even more so maybe in cats. So I would say that they are less commonly now used than they would have been when I qualified for those first 10 years following qualification. And I think there'll be some people who never use them at all. Just always now use a monofilament. When I qualified, monofilaments were still considered not very nice products to use because they were quite difficult to tie knots with. But the manufacturing process and the polymers that are now used in modern absorbable monofilament suture materials do all the things that I've just shown you, which make them actually relatively straightforward to use to tie good knots. And lots of the products, especially the polydioxanone type products, have got relatively little memory compared to what they used to have in the 20 years ago, for example. So I think it's personal choice, Daniela, a lot of it, if that's the answer to the question.
Thank you, Rob. So I think we have bombarded you with questions, and you have been so kind to stay with us a little bit longer. As I said, we are extremely grateful for your help, for your support.
It's a pleasure.
Yeah, and really, for those of you on the other side of the camera, if you know students, interns, residents that are not aware of our initiatives, please share our link, because this webinar by Professor Rob.White is really useful. It seems like not original what I'm saying, but to become a good surgeon, you need to know very well the basics, and this is what Professor White has offered us today. And so please share the link. You can find his webinar on the Facebook page, Vet on Air. I would like to thank you, Rob, because with your webinar, we now have reached, I think, over the 900 people joining the Vet on Air Facebook group, which is incredible. And also in terms of donations, we are £90 below the £2,000 donation. So please donate. As we usually say, every little helps. So few pounds, few euros, but donate and help us to go beyond the 2,000 pounds.
I agree, very much agree. If you've enjoyed these webinars and you want to watch them again, just please donate as much or as little as you can. Every little helps.
Yeah. Absolutely. So if you would like to stay with us a few more minutes, because we are now launching the next webinar by Professor Rob Fall. Rob Fall is a specialist in internal medicine, and he will talk about diabetes in cats. And every time we present the appeal, the video message from our speakers, and now I would like to ask Paolo if he could kindly share Professor Rob Fall appeal for Vets for Ukraine 2022.
Hello everybody, my name is Rob Fall, and it's a real privilege to have been asked to present one of the webinars in the Vets on Air series that we're running to help Ukraine. I will be speaking on Monday evening on the topic of feline diabetes and discussing why cats are definitely not small dogs when it comes to diabetes mellitus. I'll be chatting through why the disease develops, how we can treat it, and a little bit on where we think treatment might be going in the future. So I hope that's something that would be really informative and helpful for you in everyday practice, because feline diabetes is definitely a disease we can do an awful lot to treat and in some patients actually cure. So I hope you have time to join me on Monday evening. That all being said, I think I said it was a privilege to be speaking, and it really is a privilege to be speaking, but I wish I wasn't having to. I really wish we weren't having to have these webinars, because I really wish we weren't having to try to raise money to help our friends and colleagues and fellow humans in Ukraine. What's happened in that country in the past month is so abhorrent and appalling. And I still am struggling, like probably many of you, to come to terms with the fact that just 1 month ago, Ukraine was a completely normal, functioning democratic society with people considering and worried about their normal everyday things. And now they've gone in vast parts of the country to one that is destroyed, one where they don't know if they're going to be alive from 1 minute to the next, where their friends, family, brothers, sisters, and everyone else will be alive, where they have literally got nothing more than sometimes the clothes they wear and the company of their fellow citizens. And I think it's left us all feeling fairly helpless, and none of us can comprehend what that must feel like. Well, we're not helpless. We can make a difference. And the aim of these webinars is to hopefully give you informative CPD, but to enable us to donate. And many of you have already donated, and we're incredibly grateful and thankful for the monies that Red Cross have received through the webinars we've run. But I have a request, and that is that if you are able to donate and you haven't been able to donate yet, please do. Please do use the link that comes up on the webinars to donate to the Red Cross here in the UK, or if you'd rather donate to the national charity of your choice in your own country. We'd be incredibly grateful, and thank you very much. The second thing I'd like to ask is this, that if everybody who was watching these webinars shared the link with their friends through social media and LinkedIn, if just 5 more people from everybody, if everyone watching these webinars managed to share and get 5 more people each to watch webinars and donate just £10 or €10, we would be raising thousands more. And when you have nothing, the amount of money we're generating will make an enormous difference. So we can make a difference, we can help, and we can let our Ukrainian brothers and sisters know that we're standing with them and we're here to support them in everything we do. So thank you. I hope you're able to join me on Monday, or if not, on the recordings. Thank you for your time. Look forward to seeing you then, and please remember to share and donate if at all possible. Thank you. Bye-bye.
So thank you, Rob, for we are all looking forward to having you here with us and listen to your webinar. So please do click on the link www.justgiving.com/Vets4Ukraine if you want to donate, and spread the word and share our link. So Professor Rob.White, thank you so much. Thank you for dedicating your your Sunday morning to us. Yes, I wish you all the good, and thank you.
Thank you very much. Pleasure. Thank you very much, Paolo, and thank you very much, Daniela. It's great. Really enjoyed it. Thank you.
Thank you. Thank you. Bye-bye, everyone. Bye.
For 150 years, our people have been putting the power of kindness into action. They are trailblazers, changemakers, and lifesavers of the British Red Cross. Our very first volunteers helped pave the way for countless more, like Princess Sophia Dalip Singh, one of the thousands of VAD nurses who cared for the sick and wounded during World War I, and other volunteers who continued to help people as the war ended and influenza hit the nation hard, showing extraordinary bravery to be there for those who needed it most. Volunteer Percy Lane Oliver set up the UK's first ever blood donation service, and during the Second World War, our volunteers helped families to trace their missing loved ones, a service we still run today for refugees. We've been working alongside the NHS from day one, and with Land Rover ever since the 50s, when they started donating vehicles so workers like Joan Whittington could reach people in places they couldn't before. When a mining disaster left the community of Aberfan stricken with grief, volunteers like John Cole were there to support with kindness. And years later, workers like Helen Cookson stood firmly alongside refugees in Hong Kong fleeing the war in Vietnam. Princess Diana visited Angola's active minefields with us, leading to a ban on anti-personnel mines. Our Boxing Day tsunami appeal saw an unparalleled outpouring of kindness from the British public. And in 2017, our teams responded to a UK emergency every 4 hours. And after years of campaigning, got first aid on school curriculums in 2019, so that more children like Stephen know how to save a life. At the turn of this decade, when the coronavirus pandemic broke out, thousands joined our movement to support the most vulnerable people. And as we move forward, our vision of a world where everyone gets the help they need in a crisis will be more important than ever. Working together, we will harness the power of kindness to build connected communities that stand strong in the face of the future, whatever it brings.